Good afternoon. I'm Dr. Andrea Chisholm, Deputy Director and Chief Development Officer of the Trust, and I'm glad you're able to join us today for the eighth webinar in our AVEP webinar series titled Psychological Assessment and Treatment for Chronic Pain. Presenting today's webinar is Dr. Dawn McGeary. Dr. McGeary is a Wurzbach Distinguished Endowed Professor in Psychiatry at the University of Texas Health Science Center, San Antonio, and a research health scientist with the South Texas Veterans Healthcare System. He specializes in clinical health psychology, and his published research has appeared in high impact psychology and medical journals. In the interest of time, his bio has been placed on the slide for you. We are very fortunate to have him share his expertise today. I hope everyone learns a lot over the next 2 hours. Please join me in welcoming Dr. Dawn McGeary.
All right, thanks, Dr. Chisholm, and thanks to the Trust for having me here today. I'll go ahead and share my slides with the group, and then we can get started. Terrific. Great. Just a little bit out of the way. Oops. There we go. All right, so I am Dr. Dawn McGeary. I'm very pleased to be able to talk with you today about chronic pain management. I'll give a little bit of relevant detail about my background as I get going, but just wanted to give you a sense of the scope and challenge of a presentation like this. One is that chronic pain is so ubiquitous among the patients that we see in our practice and among the individuals that we see coming through in research trials, that I imagine almost everyone, if not everyone, in this audience has some experience with chronic pain management, has done some of it already. So I know that I'll certainly be telling you things that you may already know, but the goal of this is really to talk about the problem of chronic pain and not necessarily to get into the weeds about each individual solution. You'll see as I go through that pain is so complicated, and there are so many different ways that pain will present. There are so many different ways that pain can be assessed and treated that it would be impractical to try to include all of that in a presentation like this. Rather, this is more a description of how to think about it. And I'll show you how my way of presenting this is distilled from all of the experiences that I've had so far in my career in just a minute. Naturally, I have to do the obligatory bit of talking about disclosures and disclaimers. I've been fortunate to have a number of different research grants from a number of different federal funders, including the National Institutes of Health, the Department of Veterans Affairs, and the Department of Defense congressionally directed medical research programs. So you see here acknowledgement of the different projects that I've had and different funding awards I've had from these funders to help guide some of the knowledge that is being brought to this particular presentation. Also, as is our practice, I have to disclaim that the views and opinions that I express in this particular presentation do not reflect any views and opinions of the United States government or any of the funders who have contributed to my research over time. Those are just my opinions. In terms of my relevant background, so I got my PhD in clinical psychology in 2003 at UT Southwestern Medical Center, and that's really only relevant to this because of my mentor, Dr. Bob Gatchell. So I got to work with Bob there for several years, have been fortunate to be able to collaborate with him after, have had several opportunities to be part of his research productivity, and he's really one of the most highly cited chronic pain management investigators in the country, if not the world. So I'm very fortunate to have worked with him. Another part of my good fortune was my chance to complete the Clinical Health Psychology Fellowship at Lackland Air Force Base at what was then called Wilford Hall Medical Center. It was a great opportunity to learn about clinical health psychology and applied clinical skills, especially for chronic pain and chronic pain management. And I think it's really where I really learned a lot about how to be a good treatment provider, and that's been core to the research that I've done. And I continue to be active in research investigation and clinical work. I currently maintain a vice chair and professor position in both the departments of psychiatry and physical medicine and rehab, and that's relevant for this just because we find that a lot of chronic pain work now is very interdisciplinary. As we start to improve the way we do it, it's not unusual for us to have influence over a number of different specialties and departments in the work that we do. And I'll illustrate what that looks like as I move along in the slides later. I've also been fortunate to work with the Department of Veterans Affairs So it's, as we know, veterans and combat veterans in particular have significant vulnerability to chronic pain. So there's a lot of chronic pain, a lot of disabling chronic pain among United States military service members and veterans. And so I've gotten a chance to do quite a bit of meaningful work in those populations. And that's contributed a lot to what I've done. And then finally, aside from the research, publications and grants and stuff that I've already talked about, I've had a chance to sit on grant review panels. And that's relevant for a couple of reasons. One is I had the great fortune to be the first programmatic chair for the Congressionally Directed Medical Research Program's Chronic Pain Management Research Program. And if you ever get a chance to do something like that, and maybe some of you have, it's a really nice opportunity to look what the vision setting is for some of these research priorities, because you really get a sense, and they do a great job of including community members and individuals with lived experience with chronic pain. So you get to hear it directly from the folks who need it most about what are the priorities for this. And you'll see that that's reflected in this presentation as well. What are the priorities for our knowledge in chronic pain and chronic pain management? Where are the gaps in our knowledge for treatment and assessment of chronic pain? And then that's also come from my work as either a reviewer or a chair. I think I chair 6 panels now across the National Institutes of Health, the VA, and the congressionally directed medical research programs. And again, if you ever get an opportunity to do work for any of those, to sit on these grant review panels, it's amazing to see what's done. I've learned so much just by seeing what other people are up to. So I'm hoping to bring some of that to you as well within the confines of confidentiality for those kinds of reviews. So getting down to this specific presentation, the objectives that we want to cover today are really threefold. The first two would take priority, but if we have time in the presentation, I hope to get around to the last one as well, because at least I think it's interesting, and I hope you do too. The first objective here is really just to talk about the complexity of chronic pain overall and its taxonomy. And that's pretty important just because we make decisions about how we understand and communicate about pain, how we intervene and assess pain based on how we understand its classification. And what I hope to show is that there are a number of different ways of thinking about pain taxonomy. And so I'll point to a few of the more prominent ways of describing that. And then we'll use that as a rubric or a framework to help us understand how pain should or might be effectively assessed and then treated. And then, of course, the second part of this talk, or the second objective today, will be to talk about those assessments and treatments. And again, I'll give some specific advice, at least my particular view on it. All of this is supported by what I hope is more contemporary evidence base. But I'll talk a little bit about my views and my experience too, for whatever it's worth, and give some guidance about where you might want to look. But for the most part, it's more of a guide on how you might want to think about these things, and pointing more towards really good, usually team science evidence to support the choice of treatments and assessments for chronic pain. And if we get through that and there's time remaining, and we'll of course leave some time at the end, the last 15 minutes or so, for questions, we'll talk about some gaps in existing practice and some emerging technologies. And of course, there are different priorities for different technologies. I'm just going to talk about the ones that I've brushed up against because I have some depth of knowledge about those. Specifically, I'll talk about artificial intelligence, this concept of prehabilitation, which is the application of psychological interventions before an individual is exposed to any kind of pain insult. And then finally, cannabis and cannabis derivative drugs for pain control, which in and of itself is more of a pharmacotherapy, but it has significant implications for psychological pain management. So we'll talk a little bit about those as well. So I'm looking forward to going through these slides with you, and I'm looking forward to taking questions afterwards, but we'll go ahead and just dive right in by starting about how chronic pain is organized. And really overall, we want to start by asking the question, what is chronic pain? And when I take on trainees, so I work with a lot of psychology, clinical and counseling psychology interns, residents, and postdoctoral fellows, including medical residents as well. And I'll often start by asking them this question. You know, we talk about chronic pain a lot. It's colloquially referred to a lot. We see a lot of advertisements for it. But we have to make sure that we're all on the same page and that we're talking about the same thing. So what is chronic pain? So fortunately, we do have some guiding light when it comes to a challenge like this. Part of that comes from organizations like the International Association for the Study of Pain. I am an IASP member. I'm also a member of their Neuropathic Pain Special Interest Group. And this is a group of world experts on pain and chronic pain management. And they regularly get together and talk about how we should define pain. And I just want to show you a little bit of the intricacies of the pain definition as we start with this first slide, starting with how the IASP definition has evolved over time. So one of the first iterations of this definition is shown here at the top, where in 1979, pain was described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So here, the root of chronic pain is in the concept of tissue damage, that it's either actual or potential, but there is tissue damage and pain arises from that. But after much deliberation, and it's nice that organizations like IASP and the International Classification of Headache Disorders through the International Headache Society, they regularly come back to this concept of pain definition and chronic pain definition. And as they've done that and revisited this, they recognize that there are some pain conditions where tissue damage hasn't been isolated. We don't really know, either because it's too mysterious of a process or our technology is not up to finding it. A good example of that might be something like fibromyalgia, where we're still not sure what the underlying mechanisms might be. Under the 1979 definition, fibromyalgia wouldn't be considered pain because there is no identifiable tissue damage. Although there may be potential tissue damage that is accounted for. But in the new definition, all of the same categories apply. Pain is unpleasant. There's an emotional experience to it. But now it's that it's resembling that associated with actual or potential tissue damage. So here, it's not required that you have tissue damage. Just that this resembles what you would expect from something like tissue damage. So it just goes to show that this is not a very straightforward thing, even though we speak about it informally. We use the pain and chronic pain a lot when we talk with others around us. But the definition can be surprisingly complex. And just to give a sense of that, if you dig into the IASP taxonomy a little further, what you'll see is that there are several different dimensions that they account for when they talk about pain. The first is that pain is naturally subjective. And this, not only it's a challenge to the field, and to all of the fields that work in pain, that it's subjective. This is not something you can objectively identify. There have been attempts to come up with pain biomarkers, especially in neuroimaging, that seem to be gaining a little bit of ground, but at least in my opinion, are still not to the point where we could really defer to those as clear evidence that pain is present. Most of the time, we have to ask folks, and we have to identify ways to subjectively learn about pain from individuals. And we also have to recognize that pain is learned, which means that it can be idiographic. It's down to the level of the individual based on their own history with pain throughout their lifetime and what they've learned from their experiences and the experiences of others. We know that pain is more of a psychological concept than a physical measure. And I think this is one reason why, if you do have the pleasure of sitting on any of these chronic pain research panels for any of these federal funders, what you'll find is that you're going to be in very good company with other psychologists and mental health providers, simply because chronic pain and pain in general is a domain that is dominated by psychological constructs. And we'll talk about how that manifests in treatment, but it also means that our profession has a particularly special place when it comes, and a particularly effective place when it comes to addressing chronic pain. Naturally, pain is unpleasant and it's variable. Their mind-body interactions are important, and that the definition should also account for those who can't verbally report subjective pain, and we'll talk about that in a little bit. This is especially true of individuals who are either early or late in life and can't verbally communicate as well, but could also include individuals with head injury. So as we move on, we also want to talk, we spent a lot of time talking about pain, but we didn't spend a lot of time talking about chronicity. When I often ask people, what does chronic mean? So we were going to talk about chronic pain. What do you really mean by chronic? And oftentimes you'll get something along the lines of, well, it needs to be 3 months, 4 months, 6 months. And so I'll challenge, especially the learners that I work with. So you say pain needs to be present for 3 months to be chronic. So if pain is there for 89 days. It hasn't met the 90-day window for 3-month chronic pain. You're saying that that 89-day person is characteristically different than someone who has pain at 90 days, right? We'll say, no, of course not. So there's got to be something more to it. It's certainly we know that chronic in this case means that it's long lasting, but what's the real clinical meaning of that? How do we operationally define that? What I've really come to is, and this is really more from my clinical experience than from the research I've done, although there's been a lot of great research on this definition. But what I found is that what we're really doing when we give that 3 to 4 to 6 month definition for pain is using that as a heuristic for complexity. We think about a paper cut as an acute pain condition. A paper cut is pretty straightforward. This is a medical problem. It should be medically addressed, and we expect that it will go away. But chronic pain is much more complex. Chronic pain is this idea that you have this pain condition that is affecting several different components of your life that may be subjected to medical treatment, but may not respond in ways that you expect. It's very complicated. And I think all of that is nicely encapsulated in the biopsychosocial model. And so I would say that instead of using the numeric definition or the time definition of 3, 4, 6 months, or whatever you want to choose, think of it more clinically and think of it more holistically as, has the pain gotten to the point where a person is really biopsychosocially compromised and they've been durably compromised? For some people, that might happen 6 weeks after developing a pain problem. For some, it might happen over a year after developing a pain problem. So just think a little bit about the clinical meaning. But no, when I talk about chronic pain throughout the rest of this presentation, I'm using that clinical definition. That's what I really mean. I'm not so much interested in the 3, 4, 6 month chronicity as I am that this has now become a biopsychosocial and durable problem. There are other forms of pain taxonomy. So the IASP breaks pain down into several different categories. You can see them listed here. Some examples of what you might find in some of these categories would be, for example, generalized syndromes include things like fibromyalgia. It also includes many neuropathic pain conditions. And I'll talk a little bit about what I mean for the uninitiated about neuropathic, neuroplastic, nociceptive pain in a minute. It also includes burn pain. You'll see spinal pain across a couple of different categories. You'll see pain broken down in dermatomes. So you have upper and lower limb pain or extremity pain, visceral pain, local syndromes of lower limbs. But then if you go and look elsewhere, for example, in the ICD-11, which was influenced a lot by stakeholders from the IASP, you'll see a little bit of a different taxonomy here. Now we're thinking about what we call chronic primary pain conditions. This could include things like conditions that don't have some other identifiable cause. A great example of that would be what we call nonspecific low back pain. Nonspecific low back pain is pain in the lower back that we really can't attribute to any particular cause. And so because of that, that might fall under this primary pain category. But the ICD-11 also breaks it down into cancer-related pain, post-surgical and post-traumatic pain. We'll talk about what that means in a little bit when we talk about post-traumatic headache. Neuropathic pain has its own category here just because, as the name suggests, it refers to pain related to dysfunction in the nerves and how they work. Secondary pain, including secondary headache and visceral pain and musculoskeletal pain. So I just wanted to put this up between these two taxonomies here, which are two of the more prominent, because these are different ways of thinking about how pain might be categorized. And of course, that's important because we'll use those categories to help us identify patient populations or subpopulations that might be subjected differently to certain treatments or might be subjected differently to certain assessments. And of course, there are assessments that are specific to neuropathic pain. There are assessments that are specific to cancer pain or to musculoskeletal pain. So that seems to have been manifest. You'll also see that throughout this presentation, I included QR codes, and I did this for two reasons. One, I wanted to give you a quick way of referencing some of these resources that I bring up, especially the treatment resources. And two, I just learned how to put these in slides. So I was kind of giving away my age a little bit. This is new to me. I was excited to realize that I could easily incorporate these into the slides. So it's a new toy for me. So you'll see them scattered throughout. But I do hope that aside from amusing me, they're helpful for you. So you'll see these QR codes from time to time. And I encourage you, if you want to scan them. And that will give you direct access to these resources so you can get more depth of knowledge if you're looking for it. Some additional taxonomies would be looking at pain through an understanding of how our nervous system is functioning. And that makes sense because, of course, pain exists only because it's processed by the peripheral and central nervous systems. So if there's dysfunction in these components of the nervous system, that would also give rise to pain. So for example, we might start with nociceptive pain. This means that there's some kind of insult to the nerves, to the peripheral nerves that are then being conveyed to the central nervous system. You'll also have neuropathic pain, which means somewhere along that network of either peripheral or central nerves, there's some kind of dysfunction. It's either an injury, disease, or other process that's causing a dysfunction in how these nerves are talking to one another and how they function. And then finally, you might have overarching alteration of function for pain-related sensory pathways, which is called nociplastic pain. So neuropathic pain suggests that there's an injury or disease to the system. Nociplastic suggests that the way the system works has fundamentally changed. And this is most evident in what we used to describe, and still do describe sometimes, as whole body pain. Fibromyalgia, chronic widespread body pain, and nonspecific low back pain all fit under this nociplastic label. And we see now that we are getting some focused research in these different categories or areas that are helping guide the way we think about it. But then we also want to consider headache. Headache is unique among different pain conditions only because it manifests differently and it evidences disability differently. And we can talk about this in more depth when I talk about some of the headache research that I've done with a lot of great colleagues in my research group. One, you can use resources like the International Classification of Headache Disorders to see how headaches are classified. But when you look at headache chronicity, there is no category wholly for chronic pain. Rather, chronic is a subclassification of a number of different kinds of headaches. You'll see the definition for chronic headache below on this slide at the bottom. What I want to also point out, though, is that disability, which is really important for the work that we do in headache, is a lot different than you get from other chronic pain conditions. For chronic low back pain, for example, the pain persists. It's there all the time. And so disability is a reflection of pain that is always present. Now, it can be exacerbated. And of course, there are cognitions about that pain that contribute significantly to disability. But for headache, many headache disorders, there are chronic headache disorders that are always there, but many of them are episodic. And what's unique about that is that you get disability not only associated with the episode of the headache, but with a person's expectation that another episode is going to occur. And so because of that, we have really unique opportunities for assessment and intervention in psychology to help address disability associated with headache. Overall, though, one thing I want to put forward beyond anything else that we've talked about for pain is that we need to acknowledge that our definition of pain needs to account for complexity. That chronic pain is notoriously recognized as complex. It's very rare. What I'll often tell people is that you will never in your career see someone whose only concern is a chronic pain condition. It almost always presents with something else, whether that's insomnia, depression, anxiety, traumatic brain injury, post-traumatic stress disorder, whatever. These different conditions co-occur a lot. And in fact, they tend to occur in bunches. For example, the U.S. Pain Foundation did a survey of adolescents and children with pain and talked to the children and their families and asked them, like, what's going on medically for you? And what they found is that about 80% of kids who have a chronic pain condition have at least 3 additional chronic health conditions, and that includes mental health conditions that come along with it. Something else that we find is that these burden one another, they influence one another, these comorbid conditions and pain influence one another, and they change the way individuals respond to both assessments and treatment. So understanding complexity is really crucial to working in chronic pain patients. And because of this, it's really important that we as treatment providers recognize this and incorporate this thinking in the kind of assessments we do. And I'll talk about that in a little bit. And this is also important because from a patient-centered perspective, in another U.S. Pain Foundation survey, they found that 2/3 of individuals in the United States with chronic pain don't feel understood or cared about by their healthcare providers because they feel like their healthcare providers do not recognize or understand the complexity of their pain. One other downside or difficulty of this complexity is that it tends to lend itself, because it's so complex, to specialty care. And you'll see this as you watch our individuals or patients or clients with chronic pain navigate their way through the healthcare system, they'll tend to start with primary care, work their way into specialty referrals, and it's usually about 4 or 5 referrals before they find their way to a psychologist or counselor who has some knowledge of chronic pain management. But what that means is they're dealing with specialists who are focusing on only one component of their chronic pain picture. And that can make treatment ineffective, actually, but also leave the patient feeling really poorly understood. So it's helpful for us all to have a perspective of complexity right away and try to bring that to the patient as quickly as possible. When we think about the specimen of chronic pain, one of the most important questions that confronts us as a field, and us being all science and clinicians working with chronic pain, is this idea of chronification. And chronification has really started to take on a lot of emphasis, especially in funded research, just because we recognize that the process of the development of chronic pain will give us a lot of clues about what chronic pain actually is. There's a lot that we can infer from a tertiary standpoint, where patients who have already developed a chronic pain condition are living with it and manifest it. But if we could identify what this mechanism is that might be converting acute to chronic pain, that would go a long way towards helping us understand it. There are models that are out there, and I will say that my particular perspective, at least from the positions I've had on research panels and as a clinician, as someone who is a regular consumer of knowledge about this and talks regularly with other people about phenomenology associated with chronic pain, is that although we have a number of models that have been proposed, I think we still don't really understand how pain chronifies. You see a couple of examples here. The one on the left is rooted in how the nervous system is functioning. That makes a lot of sense. It's possible that there is a creep of dysfunction within the nervous system, and it may have genetic components. It has neuroplasticity components that might give rise to chronic pain. There's another one to the right that accounts for some of that, but also suggests that there might be additional nerve injury. There are sociodemographic variables that are important. There's, of course, pain experience and sensitization. We'll talk about sensitization in a minute because that's another high priority item. And there's probably some changes in gene expression. So some of this epigenetic stuff that we're starting to see a lot of that's contributing to pain chronification. But these are just two of several different models. And right now, I don't know that there is any one predominant model of pain chronification. And there are some who suggest that pain chronification may not even be the problem. That perhaps, and I think it's important to take on this perspective because we don't want to get locked into one way of thinking. There's some who suggest that chronic pain, can arise in some individuals who never had an identifiable acute pain problem. And because of that, then maybe it's not so much that we're looking for a chronic or a chronification mechanism, so much as that we're looking for an array of risk factors that accumulate over time and then evolve or culminate in chronic pain clinically. And if that's the case, then of course, as you can imagine, that's another line of research and another way of looking at it. And there are some individuals who are moving in that direction. I think this body or this corpus of research is still relatively young. And so because of that, it's actually exciting for all of us. We're learning as we go. But I also use this as context for a plea that in your research or clinical care, if you do learn something new or have an idea, please share that with the field. We're at a point now where we really do need to learn a lot. And if we care the way we say we care about individuals who are suffering and have significant disability and have significant quality of life issues because of the chronic pain that they're experiencing, that we need to do all we can as a field to really try to help them as quickly as possible. And one way we really succeed in doing that, at least in my view, is by sharing what we know and using our collective experience. We'll talk just very briefly, so I'll go through these slides quickly because I think we all know what the epidemiological picture of chronic pain is. It's very prevalent, it's very costly. It's very costly in terms of treatment costs. It's very costly in terms of opportunity costs, direct and indirect costs associated with presenteeism, absenteeism, missing work, missing opportunities to engage in meaningful social activities, recreational activities, and family activities. And it has a devastating effect on the quality of life of the patients who experience it. Just to give some specific numbers to that, approximately 1 in 5 US adults have endorsed a chronic pain problem, at least back in 2021. You'll see that there's a confidence interval around that goes anywhere from about 10% up to, in some cases, 40 to 50%. And when you look in some specialty populations, I'll talk about that in a second, or some subpopulations, you'll see that the risk can actually be higher for some. About 7% of US adults endorse what we now call high impact pain, which means that not only are they having a frequent experience with a pain problem, but that experience is having a significant impact on meaningful life and work activities on most days. And as I mentioned earlier, pain prevalence notably differs across different populations or subpopulations. And one example of that would be with older adults. We know that older adults are uniquely vulnerable to chronic pain, and that makes sense. Even if you look at it from just a musculoskeletal standpoint, that the body takes wear and tear over time. That wear and tear can accumulate as we age. It creates vulnerabilities in the muscles, bones, and joints, and those can give rise to a higher likelihood of chronic pain conditions. And you see some of the prevalence listed here. Of course, there are risk factors like higher levels of mental health problems, higher BMI, and lower expectation of recovery from pain when acute pain problems exist that can increase that prevalence for some people. And we do see that there are also some protective factors that have been identified. I will say, though, that I think much more needs to be done, and the National Institutes of Health and the National Institute on Aging agrees that we need to focus more on working on effective solutions for older adults for pain management. We also know that veterans, and of course this is near and dear to a lot of the work that I've done, veterans are vulnerable to chronic pain problems. And we see really high prevalence estimates, about 30 to 51% is what's been documented in several cases. And you see the confidence at 95% confidence intervals next to those percentages there. And so this is especially true for individuals, for veterans who have a traumatic injury. Chronic pain often presents in the context of major depressive disorder, generalized anxiety disorder, significantly increased risk for suicide and suicide attempts, and of course PTSD. And so this can be an incredibly complex problem for veterans. And then finally in children. And some people are surprised to hear this, but children are quite vulnerable to chronic pain problems. And this includes problems like headache, but also traumatic injuries and durable injuries from that. I've seen individuals with interstitial pain, adolescents who have developed pain in their ribs and neck. So this is a fairly prevalent problem, and you can see the prevalence across different pain types on the left here. Worldwide, prevalence of chronic pain in pediatric samples has been estimated up to as high as 1/3. About 3% of kiddos require intensive rehab for their pain. And so we're starting to see more emphasis on developing programs specifically for pain rehabilitation, interdisciplinary rehabilitation for children and adolescents. I was very fortunate to be able to work a little bit with the Mayo Clinic to put together a headache clinic for adolescents, especially those with migraine who were really suffering. And if you think about it, pain in adolescents and children is particularly unique because of the kind of disability that can come along with it. Children exist in a unique infrastructure, a unique world. They have a school world. They're still learning, and their schoolwork impacts their future life. They have a home life that is unique in their relationships with their siblings and their parents and caregivers, and also, of course, interactions with their peers. We're also working with children from young to adolescents who may have difficulty articulating the complexity of their experience. So it can be hard for them, and that makes it difficult for assessment. And of course, good assessment is a requirement for good treatment. So we have unique challenges working with pediatric populations. And you see some reasons for why prevalence might be growing over time there. So that's just really some of the intro or background to chronic pain, just to give us a sense of where we're starting. But now it's time for us to dive into the nuts and bolts of actually doing something about it. So I want to go through and talk a little bit about chronic pain assessment, followed by chronic pain treatment. And as I do that, just an entree to all of this, or a preamble to all of this, is to say that I'm going to give you some perspective, but of course, it is not going to be a universal perspective. One, I'm not smart enough to be able to be aware or know or understand all the different options for chronic pain treatment that are available out there. But I have had some experience with some and can turn you on to some resources that show you really good evidence-based options. But I just want you to recognize, and I'm sure that you already do, that these are just options. They may not be the best options. They may not even be good options for some of the patients you see. But generally speaking, when we do assessment, we know a couple of things, especially rooted in what we just talked about. One, pain is complex, so it's fully understandable. And I think we need to expect that when we are going to assess for chronic pain, we are not just going to have one assessment. In our assessment battery, there are going to need to be several because we need to cover the meaningful dimensions of it. And these can be rooted in the biopsychosocial model. So we can use that as some guide, give us some guidance on how to thoroughly assess pain, or at least get to the components of pain that we think are clinically important. But we also know that pain is variable, not only from person to person, but over time. So we know that different pain conditions might need different measures. I mentioned earlier that there are assessments that are specific to neuropathic pain. There are assessments that are specific to cancer-related pain. So we might need to dig into some of those for some individual patients. So you're not necessarily going to have a one-size-fits-all battery of assessments for everyone that you see. So we will start with that, but then we're going to move on now and talk about what is probably the most ubiquitous, widely talked about, and most thoroughly, not thoroughly understood, but most thoroughly discussed pain assessment, which is the numeric pain rating. So when we think about pain assessment, and whenever I'm talking with learners or talking with at scientific or clinical professional meetings and presenting on something like this, I will always ask the audience, what's the most common, or what do you, in your experience, what's the most common or frequent way to measure pain? And it almost always starts with this pain rating. So it's important for us to really not give that short shrift. And I worry that some people have. Actually, I take that back. I know some people have given it short shrift, and we'll talk a little bit about that in a minute. But when we really sit down and think about what does a pain rating mean, it's shockingly complex. My running joke with people around me when I talk about my history of experience doing this, and I'm not a pain assessment expert. There are definitely some who have much more experience, and I'll identify them as I go through. But I have done some meaningful work in this area, starting with my dissertation, and my dissertation was focusing on the numeric pain rating. And my joke is that the numeric pain rating, this 1 to 10 or 0 to 10 pain rating, is actually so complex that I managed to write a 300-page dissertation on it. And I also looked at the visual analog scale of pain, where you make a mark on a line. So my joke is that I wrote 300 pages on a 10-centimeter line just to try to describe how complicated this is. So let's get into it. Let's talk a little bit about what pain ratings might encompass. So of course, the first, and we all make this assumption, and I think to some extent it's true, is that pain ratings represent nociception, or the neurological basis of pain. What a person is feeling, what's being conveyed through the nervous system to the brain and processes pain. I think that is reflected in the pain rating, but it's really not the only thing. It could also reflect whether or not someone feels like they have adequate resources to manage the nociceptive pain they're experiencing. So if they feel like they don't have a lot of resources, then their pain rating is likely to go up. It could also mean whether or not they feel like they have social support. And it's not just that they feel like they're supported, but whether or not they feel like the people around them not only understand them, but believe their pain experience. I've had several patients with really high pain ratings who tell me that part of the reason why that pain rating is high is because they just feel like their family or their primary care or specialty providers don't believe them. And this is a unique problem that we psychologists and mental health providers experience, because they show up in our office often or sometimes as a turf from other providers who have given them the message, either directly or indirectly, that the pain is in their head, so they need to go see a mental health provider to deal with it. And so that can be very tough for our patients. It leads to some distress. And also there's anxiety, which I think is really just endemic to chronic pain. And it makes a lot of sense, right? That when you're experiencing a durable problem like pain, which is a signal of damage and problems in the body, that's anxiety provoking. Is of course anxiety and generalized anxiety as a comorbidity for chronic pain is very frequent. Of course, as we have anxiety, we have distress. We also have poor sleep. Depression naturally occurs. The pain rating could be rooted in a person's culture and how they individually think about pain, social constructs as well. And then finally, their age could give rise to the pain rating. So all of this, of course, is encapsulated in one single number that we use as a surrogate for all this stuff. And we call this their pain rating. This is your pain rating. We use, ostensibly, we're supposed to use this to guide how we treat pain and whether or not treatments are working. But one difficulty of that is we know that all of this stuff is crammed in there for everyone. We have no idea what the weights are. And of course, I think if we were to look at this in a sober way and really think about it, we would recognize that every individual is going to have different weights on all these different components of the pain rating. So in a way, it makes the numeric rating for pain probably one of the most useful and useless ways to measure pain overall. But we use it a lot, and I think we'll continue to use it a lot. And that's why work by individuals like Mark Jensen, who's really done a great job, and I'll highlight his work in a minute, has done a great job of shedding some light on the weaknesses, but also the potential strengths of the numeric pain ratings. That's why that work is so important. So why do we use numeric ratings for pain? One is it's easy to do. So we can do it in a very brief period of time. I'm not so naive as to think that I'm sitting here telling you, hey, we need to have a really long, comprehensive battery if you want to honor the complexity of chronic pain, and think that you can easily work that into your clinical care. That would be a very naive thing to do. So we do have to find simplified ways. One simple way of doing that is to use a numeric pain rating. Another reason to do it is because everyone else is doing it. So if we want to have a common outcome, this is one way of doing that. And then if you look across chronic pain management research, especially for pharmacotherapies and invasive interventions and technologies, the primary endpoint for these would be this pain rating. It is what is considered the most important outcome for many of these research trials. And then for many people, it seems to make sense. But of course, we as a group know better, right? We just talked about the complexity of it. I do want to take a minute and just talk about the numeric rating scale for pain and an object lesson of being over-reliant on the NRS. So back in the 90s, the American Pain Society really pushed the numeric rating scale or numeric pain scale or numeric ratings for pain as what they call the fifth vital sign. In other words, they were encouraging medical providers and physicians to incorporate pain measurement into all of their activities. Every time they see a patient who has a pain complaint, they should be assessing for this stuff. And ostensibly, that would mean that they're doing a better job tracking it, identifying it as a problem, and treating it. And then what came along with this, though, was that there wasn't a lot of rigor in terms of interpreting what pain ratings were actually telling people. So they interpreted it almost exclusively as a nociceptive measure. And because of that, it started to give rise to a lot of push from the Joint Commission, from the American Pain Society, and of course from drug companies, sorry, who are developing pharmacotherapies to promote opioids for pain management. Of course, we know that that led to the opioid crisis. And a lot of that had its root in this over-reliance on numeric ratings for pain measurement. So we do want to be careful about how we measure pain and how we interpret it. Strengths and weaknesses for the numeric rating scale for pain. One, patients do find it easy if it's structured in a certain way. I'll talk about that in a minute. It is customizable, so you can anchor it however you want, and I'll give some recommendations for that as well in a little bit. And there is, of course, meaning to it. We just have to be open to the complexity of that meaning. But why might we want to not necessarily avoid, I shouldn't have put avoid there, but we should use NRS with caution. So we should use pain ratings with caution. One is because it lacks face validity. And this is the weighting question I talked about earlier, is that I think when we do ask our patients to give a pain rating and we're not clear about what we're really trying to get from them, it means that our interpretation might be off. And this has been shown in studies of healthcare providers, and they asked about what does this mean, this pain rating mean? What do you expect? And there's a lot of variability in their responses. Meaning may change based on who asks, and I'll show you some evidence of that from studies in my own lab in a second. And there's also a concern about serial dependency. And what I mean by that, or serial dependency, also called or autocorrelation, is that individuals, if they're able to remember the pain rating that they gave the last time they saw you, they're going to use that as a guidepost for what their pain rating is going to be the next time they see you, instead of what their pain actually is. So it causes a little bit of range restriction in pain ratings, because a person is thinking, well, I gave a 7 last time, I'm doing a little bit worse, so I'm an 8. Whereas they may have come in if they were just giving you a rating de novo without having done it previously and given you a 9 or a 10. So these ratings can be dependent upon one another over time. That makes it somewhat difficult for them to vary. And then finally, pain ratings may not correlate to other important measures. So it's really not, we can't expect pain ratings to be an effective surrogate for other assessments for pain. I'm going to talk a little bit. You see some of the graphs here, but I'll just break down the study that we did. This was led by Dr. Meredith Stensland, she's a collaborator in my research group here at the University of Texas Health Science Center. Or sorry, we just changed our name. We're now the University of Texas San Antonio Health Science Center. And what we found, and this was actually a serendipitous finding from another study, was we were asking people to give pain ratings within just a couple of minutes, anywhere from 3 to 10 minutes from the time they gave a medical provider a pain rating. And we didn't realize this was occurring, that they were being doubly assessed. And the order of pain ratings between the researcher and the clinician were sometimes switched. Sometimes the clinician would ask first, sometimes the researcher would ask first, but it was always within 3 to 10 minutes of each other. And what we noticed was there was not a lot of correlation between these ratings. And invariably, the ratings that they were giving their medical providers, and these were individuals who were presenting to a specialty pain clinic for lower back injections. The ratings that they were giving their specialty providers were a lot lower than what they were giving the researchers. And because this is serendipitous, we didn't systematically vary the different characteristics of the individuals who are assessing. So there may be something about the demographic characteristics of the individuals who are assessing and how they present, their friendliness and other non-specific factors in the way they present to their patients. But it's interesting to know that the pain is a social construct, that it may be different based on the stimulus value of the person who's asking. So that's another reason why we should think carefully about using pain ratings. So how should we use them? And how do we consider their level of data? A lot of times, I think people do fall into the trap of thinking that numeric rating scales can be used as a ratio level data, because you have a 0 and you have a 10, and we can give it a mean and a standard deviation if we have a group of individuals, and we think that the distribution of those data will be suitable for certain statistical tests. But what we find is that even though you can mathematically do that, you can say that a rating of 4 is half of a rating of 8, but the widths of the categories, so the distance or the meaning of a difference from 4 to 5 is different than the meaning of a difference from 7 to 8. Those widths are not the same. The meaning of that change is not the same. So we really can't think about it as ratio data. We can also vary the anchors that we use to help guide how we use numeric rating scales for pain. So for example, I prefer behavioral anchors. The most common anchors that are used would be 0 means no pain and 10 means the worst possible pain. I'll often change that, especially in my clinical care, and say 10 would be pain that's so severe that you need to go to the emergency room right now. And I do that simply because it prevents people from coloring outside the lines. There's no 12, 13, or 14 for that. You either need to go to the ER or you don't. But then 2, it's a nice way of behaviorally checking someone who might come into my office and say, well, my pain is 10 out of 10 right now. Oh, so do we need to walk you to the ER right now? No. Okay, well, yeah, you're right. I see what you're saying, Dr. McGarry. Okay, maybe I would say it's a 9. So it does help calibrate a little bit. And then finally, scaling. And there's been quite a bit of good work on how to scale this and the psychometrics of it. From a patient perspective, using fewer numbers tends to be better. There are some numeric rating scales that will go from 0 to 100, but patients find those to be way too complex. So really stick with an 11 point or less. Patients tend to like 5 the most. And then having a whole midpoint helps. And what I mean by that is that if you use the typical 1 to 10 scale here, the midpoint for the 1 to 10 scale will be between 5 and 6. And for whatever reason, that doesn't make sense to patients. It's helpful for them. They're more psychometrically sound in their ratings when that midpoint falls on a whole number. So if you instead use an odd number of numerals here and go from 0 to 10, now the midpoint falls on 5, which is a whole number, and that's a lot easier for people. As 5 is the middle, now I can break it down. Instead of having 1 to 10 as a whole, I can break it down from 0 to 5 and 5 to 10, the upper and lower half, and rate within that. So it tends to help a little bit with the psychometrics. As I mentioned earlier, another good way to use numeric ratings, though, for pain is to ask Mark Jensen. Anyone who's had the pleasure of working with him, I think he's at the University of Washington now. One, he's really nice, a great guy, great person to work with. I've approached him with questions about pain measurement over time, just with cold calls and emails, and I really don't know him that well. And he has always been very gracious in the time he's willing to spend with me to help me orient myself to pain measurement. Some of the things that he's identified in his work would be that numeric ratings tend to be better than visual analog scales, at least under certain circumstances, that there are some cultures that may respond better to non-numeric scales, recognizing that variability within individuals can be helpful, which means that if you can repeatedly give pain ratings and look at that variability, it might be nice. And then finally, having composite scores can sometimes be helpful for interpreting these pain ratings. What I mean by that is giving multiple ratings and taking an average, although some of Mark's more recent work suggests that just asking once a day about their worst pain might be quite meaningful in and of itself. So again, I think consuming some of the work that Mark Jensen has done can really go a long way. But if I was going to distill this all down into a few just little bullet points or recommendations, is one, we have great options now with electronic pain diaries. So there are apps that a person can download to their phone. And I don't have any specific recommendations. I'm sure you may already be familiar with some that are easy to use, but it can be really nice to aggregate those data over time. Also talk about the ratings with your patients or clients and what they actually mean. So this is where we go back and really talk about the face validity of this, what we're actually really talking about. I've already made the third point there. So next is just don't over-rely on pain ratings for treatment guidance. We do use it as a primary endpoint for research. What we find is that for psychological interventions, pain ratings don't really move a lot. And I think it's because we're not contextualizing them well. And we're not following the advice of people like Mark Jensen who are helping us learn a better way of using pain ratings. And when we don't do that, I think we fall flat in terms of outcomes. So just don't over-rely on it. Be very careful if it is the only way because of whatever circumstances you have that might limit you to just one measure. If you want to choose the NRS, just be thoughtful about it. So we've talked about the numeric rating scale for pain. I wanted to give it more depth than any other measure simply because of its ubiquity. But now we do need to talk about other measures. There are hundreds of options. There are so many different ways, especially when we think about the multidimensional model or the biopsychosocial model of pain. There's so many different ways that we can go about assessing it. Because of that, we have so many options that it defeats the purpose of a presentation like this to cover them all. So as I mentioned earlier, I want to start just by talking a little bit about how we can think about that and where are some good resources that can help guide our thinking and help us do it better. So first, and this is another product of Mark Jensen's work, is to think about empirical support. And remember that empirical support doesn't necessarily or exclusively mean support coming from research that we're doing. It could be a support that's coming from your own clinical observations. And I tell a lot of my learners here that in the absence of any other good measure, it might be just being able to rely on good theory or common sense. Like this just seems to make sense. But of course, the highest point of all of this is something that is supported by repeated or replicated research. There are groups that have come together to help really guide our thinking about multidimensional assessments for pain. That includes groups like IMPACT, the NIH HEAL Initiative, and BACKPAC. I'll talk about those in a minute. But in the end, also don't be afraid to talk about your own measure. Recognize, and I said this earlier, that chronic pain is going to manifest differently for everyone. everyone's going to show up with a constellation of all the different pain comorbidities and all the different components of pain that we discussed earlier, but they're all going to be weighted differently, and some are going to be more prominent for some people than others, and some are going to have very unique factors that may not be accounted for in measures. So don't be afraid of coming up with your own assessment, especially one that's patient-centered, and I'll talk about that in a little bit. So the IMPACT initiative, so this is the initiative on methods, measurement, and pain assessment in clinical trials, have done a really wonderful job of coming together with guidelines and recommendations and resources for thinking about pain assessments. You have a QR code here that will lead you right to their website. And you can find a list of all the impact and action publications at the link below there. They identified at least 2 different core domains, and they talk about pain intensity, measuring physical functioning, emotional functioning, overall improvement. We'll talk about what that looks like in a minute. Pain symptoms, adverse events is really important. So when a person is exposed to certain treatments, even psychosocial interventions, there may be adverse events, and tracking that can be helpful. And then finally, measures for treatment adherence. We don't have time to go into all these right now, but if you ever have a moment and you're serious about improving the way you're assessing pain, comb through some of the work that IMPACT has done, including their ubiquitous or frequent publications, or numerous publications. They have a lot of them. You can also look at the NIH HEAL initiative. Of course, there's a lot of overlap between HEAL and IMPACT. HEAL was pulled together as part of the Helping to End Addiction Long-Term Initiative for NIH, but has a really strong component dedicated to chronic pain management. HEAL has made their own recommendations about core domains that should be assessed for chronic pain, and of course may be incorporated into multi or interdisciplinary treatments. You see that array here, and what you'll notice is that, one, it's similar to what we see for IMPACT and what their core domain recommendations are, so it's nice to see that replicated. And it's also very reminiscent of the biopsychosocial discussion we had earlier. So this is one case where this did come out of a lot of consultation from experts across the country, a lot of evidence-based research, and a lot of clinical experience. But it also really just makes sense when you think about the biopsychosocial model. Of course, we would think about sleep. Of course, we would think about cognition, and we would think about anxiety and the physical component of pain. We think about comorbid conditions like substance use disorders, concepts like pain interference. We'll talk about it in a little bit, but it's defined as the interference of pain in meaningful daily activity. And then, of course, treatment satisfaction. For the sake of time, I'll skip this. FAIR is just how NIH HEAL Initiative makes their data available and encourages component research to ensure that they're giving data that people can find easily and use well. And then here are some just for common data elements. The HEAL Initiative makes recommendations. Now, although this is relevant to research, I think this is something else that could be relevant to clinical care as well. Is that if we're giving the same treatment and we want to give it over and over again to the patients we see, having some common elements of pain assessment across those treatment iterations and across those patients can really help us develop a corpus of research or a corpus of data within our own clinical practice that helps us understand how well that treatment might be working, and might help us understand how, for whom that treatment might be working or might be particularly ineffective. So you see some examples here across different domains. I mentioned earlier that there are recommendations for patient satisfaction, and so that generally comes from measures like Patient Global Impression of Change and patient satisfaction scales. These are 2 that are taken from my cannabis trial in the VA, and I just wanted to show you a little bit for those who are uninitiated of what these might look like. The PGIC, or the Patient Global Impression of Change, is you'll find that increasingly used in research. And the reason why it's used is because it's very patient-centered. This is an opportunity for a patient or a participant or client to be able to tell you, this is how much I thought that what you did with me led to some kind of improvement or worsening in my pain. We can link that to changes in other measures like the PEG, or like the numeric rating scale for pain, or like the PCS, to help us understand the clinical significance of changes in those measures. So I really like using the PGIC both in my research and clinical practice. It's quick, easy to do. You do it at the end of treatment, so you only really have to do it once, although you can do it throughout. And then also linking that with patient satisfaction. Just a funny tidbit from a presentation I did a while ago for a pain group here on patient satisfaction is that patient satisfaction is actually surprisingly complex, and it's not necessarily limited to what's happening in the clinic or the treatment itself. there was a group that looked at pain treatment and patient satisfaction, and they looked at a number of different components qualitatively to see what variables or what circumstances weigh the most on patient satisfaction. And they noticed that for pain patients, the most significant contributor, at least in this one study, and I think there might have been 140 people in it, the most significant contributor to patient satisfaction was the distance between the parking lot and the clinic front door. The further that distance was, the less satisfied patients were, and that makes a lot of sense. If it's a hassle to get to the clinic, they're going to be less satisfied, and that's going to color the interactions that they have with their providers there in the clinic. So I just like to use that as an example. One is an aha moment for me, and I thought, okay, yeah, I think, I mean, to whatever extent we can, we try to control that, be better about it. But two, we can't take patient satisfaction for granted. Another resource for you would be the NIH PROMIS measures. So PROMIS is the Patient-Reported Outcome Measurement Information System. This was developed by the NIH using advanced psychometric strategies, including computer adaptive testing and item response theory, to develop measures specific to different dimensions of chronic pain. You can find these digitally or paper-based measures. And they assess a number of different domains. I don't have time to go into all of them. As you can imagine, because they're coming through the NIH, they're very, very well researched, and they do touch on different components for different specialty populations too. So for example, you'll see the NeuroQoL short form for pediatric pain. Here, they have pain impact, both long and short form, pain episode frequency and severity. They have their own NRS measures for pain intensity. They have pain behavior measures, neuropathic pain measures, and this is just a subset of the 3 different pages in this list. So it goes on and on. There are at least 60 measures they have specific to pain in the PROMIS, and that's just for pain. They also have measures for things like depression, anxiety, substance use, a number of different comorbidities that are important. So if you're ever interested, you can peruse the PROMIS. I have a QR code and the web address for you there to find measures that might be helpful for you. And then finally, BACPAC. So BACPAC is a consortium. It's the back pain consortium within the National Institutes of Health that came together specifically to look at measurements for back pain, have made recommendations that are similar to what we've seen from other organizations in terms of the breadth and depth of pain measurement. And then make specific recommendations about different measures that you might be able to use to address these different domains across different categories or dimensions of pain. One notable thing about BACPAC is they also created single item measures for certain dimensions that they felt were not well addressed by existing measures. And you can see some examples of that here. But the takeaway from that is that it can be done, and it can be done well. And so they were very careful about making sure that they established some kind of content validity for the item they're putting together. Does it actually measure what we say it measures? They did assess the reliability of these single item measures over time and have established their psychometrics and are able to assess components of the pain experience that weren't otherwise accessible for things like somatization, financial strain, perceived discrimination, and cognition. So it's really nice to know, and it's encouraging for us because as we confront diversity in pain treatment going forward, we can develop items ourselves. And I think I say this just more out of self-discovery. Despite the fact that I've been in this field for 20 years, I still do need to remind myself from time to time that these things can be done. So it's a really nice reminder for that. Of course, we must acknowledge that there is a clinical interview for pain, and a good interview, of course, should be multidimensional. It should cover a number of different domains, including factors associated with the pain experience, not only the experience of pain, but the experience of pain treatment, how an individual copes with pain. And I will tell my learners and junior faculty mentees that you also need to consider both healthy and unhealthy coping responses, because we can amplify healthy coping and try to diminish unhealthy coping. Changes in quality of life, especially recognizing what quality of life looked like both before and after pain onset. That helps in goal setting. Pain-related fears and catastrophic thoughts to address the cognitive dimension of pain. Protective factors that can improve pain coping, then have real-time observation of pain behaviors. So, and all this means is that I'll often encourage people to, if you have someone coming in with a lower extremity pain complaint, notice their gait, notice how they sit. listen to any kind of audible utterances when a person sits down, groaning when a person sits down or stands up. There might be gritting of teeth, facial grimacing as well. Notice those things. Notice their relative frequency, because that can be part of pain assessment and can be used to determine success over time. It's also a component of how individuals function socially with their pain. It's also within pain coping, I wanted to talk a little bit about a couple of prominent ideas or concepts within this idea of pain coping, both cognitive and behavioral concepts, starting with pain catastrophizing and chronic pain acceptance. So pain catastrophizing is tough, and I have a slide to talk more about that in a second, because there's no widespread agreement on what it is. Naturally, it does incorporate cognitive components in pain experience, but it also may represent a breakdown in pain coping. And there are other elements of what we would describe clinically as worry about pain. If we wanted to describe pain catastrophizing by its most ubiquitous measure, we would look at the pain catastrophizing scale, it would suggest that there are components of pain catastrophizing that describe pain rumination, so repeated thoughts. I can't stop thinking about this pain. Pain magnification, this is the worst thing that's ever happened to me. And pain helplessness, there's nothing I can do about this pain. Chronic pain acceptance is another domain and this is really well defined actually by the Chronic Pain Acceptance Questionnaire. This is developed by Kevin Valls and his colleagues. And if you ever get a chance, Kevin is another individual who is really gracious, easy to work with, and lucky too, because he's now living and working in Ireland, and he has never declined a request from me to talk a little bit more about pain acceptance, and has been formative in the work that he's done in chronic pain acceptance. And this includes pain acceptance as a context, as a concept, and I'll give a little more depth to this in a minute. Includes components of activity engagement, which is in participating in activities that are valued or important to a person despite the fact that they have pain, and pain willingness, which describes refraining or a person's willingness to engage or refrain from activities from ineffective pain reduction strategies. So pain catastrophizing, as I mentioned, it has been thoroughly researched, but there's no widespread agreement on a theoretical or definition or conceptual model of what it is. So we just have to think about what it could be, which would be, it might be catastrophic worry. It might be unsuccessful problem solving. It might be just having a negative mental set related to pain and chronic pain experience and treatment. There might be a component of cognitive constructs contributing to emotional regulation, and also this idea of interoceptive sensitivity, which is just sensitivity to physical symptoms that come along with pain. One thing about, and one reason why pain catastrophizing should at least be considered as part of your assessment battery, at least sometimes, is just because pain catastrophizing seems to be strongly linked to a number of different pain outcomes, and meaningful and important pain outcomes. So I look at it, sometimes this is an outcome, but for me, it's mostly a process or mechanistic variable. If change is occurring, my suspicion is, and it's beneficial, that one of the ways it might be benefiting my patients is through changes in pain catastrophizing. For pain acceptance, here on the right-hand side, you see an example of the pain catastrophizing scale. I think it's in the public domain, so you can just go out and grab it and pull it down, but that's a really nice resource for you. For pain acceptance, so pain acceptance is specifically described by Kevin Valls and other people like Lance McCracken and Chris Eccleston, who have done all this work in acceptance commitment therapy for chronic pain, as having painful experiences without their overly influencing functioning. So it's this idea of being able to be in the moment or in the circumstance of experiencing pain, but being able to engage in meaningful activity anyway. So this is, of course, strongly related to ACT. It is a way of behaviorally or radically behaviorally addressing maladaptive cognitions. Of course, there is mechanistic overlap with pain catastrophizing. Studies that have looked at mindfulness, pain catastrophizing or cognitive components, and behavioral or ACT components for pain management suggest that there's quite a bit of overlap between the three. But we do know that when pain acceptance occurs and occurs well, that it contributes, and we'll talk more about this when we talk about treatment, it leads to good pain management outcomes. So measuring it can be important. The Chronic Pain Acceptance Questionnaire, which Kevin Valls and his colleagues have developed and shortened over time, is a really great resource for this. You see an example of that to the right and a reference for that if you want to go out and grab it. It's great to use. Just a small comment on pain assessment in children. I do work mostly with adolescents. I don't work a lot with younger pain populations, so I'm really not a person to ask about that. I know there's some great work out of Stanford in pediatric pain, so that's a wonderful group to work with if you're interested in more. But some things we do know about pain is that in children is that pain assessment in children can be challenging, especially for children who are preverbal or who don't have the verbal skills necessary to really describe pain in depth or to understand pain assessment concepts. Pain scaling, so using a numeric rating scale for pain, or using any kind of progressive scale for pain, like the FACES scale, it can be challenging for kiddos, especially kids under the age of 11, because they have a challenge understanding the concept of scaling. And we know that over half of children under the age of 7 can't seriate pain ratings. So that autocorrelation we talked about earlier gets thrown out, but you get a lot of variability that makes it difficult to make sense of pain ratings with younger kids. There is some guidance that's out there on how to improve it. Again, I'm not the person to really go in depth about how to do that. But I do think it's important if you're working with pediatric populations that pain is a concern to really do some consultation, do some deep dives into how pain is assessed in children, and try to use some of those good evidence-based measures that Mark Jensen encourages us to use to do that kind of assessment. So if you were to ask me what my recommendations are, I've already foot stomped the importance of taking numeric rating scales for pain with a grain of salt, and then really considering best practices for using them, including self-report measures. So I like self-report measures of function. One I use a lot is the Oswestry Disability Inventory, but there are a number of different measures for this. Self-reported measures of function, at least in the research I've done, seem to do a better job of predicting a person's activity than actual objective functioning coming from something like a functional capacity evaluation, which measures strength, flexibility, and aerobic capacity. And it's because a person's perception of their ability to get something done has a lot more weight when they make decisions about activity than a person's actual functional capacity. So incorporating a measure like that from time to time can be helpful. Developing a patient-specific measure of pain and pain experience can be important too. And then finally, consider measuring mechanisms and measuring comorbid conditions. So let's talk now a little bit about pain management and pain intervention, especially psychological interventions for pain. We run into the same problem here, is that as we did with assessment, there are many options, and that's a blessing and a curse. You know, the upshot of it is that there is a large pool of information, a large pool of evidence, and a large pool of resources for helping individuals learn how to manage chronic pain. The downside is you got to pick. You got to figure out which one is going to work for your patients. Now, I think some of the grace in psychosocial interventions for chronic pain that is not shared by pharmacotherapies or invasive interventions would be that psychosocial interventions tend to be a little more broad spectrum. So even if you pick the wrong spot, you're still going to affect components of pain experience that are going to help somebody. But if the goal is to pick the best treatment, it can be really tough to do. So guidance is necessary, and where do we start? So one place I want to turn you on to, which this is a recent development, is the APA clinical practice guidelines. So APA from time to time has published clinical practice guidelines for pain management and psychological approaches to pain management. There's a group that recently met specifically for chronic musculoskeletal pain in adults. And they make a number of different recommendations and describe the state of the evidence. And this is a really great work because national experts are brought on board. I'm lucky I get the inside scoop because one of those national experts is Cindy McGarry, my wife, and she is also a professor here in the Department of Psychiatry. Her office is actually on the other side of my back wall. So I'm very fortunate that I get to work with her daily. She has done very meaningful work, not only in chronic pain and interdisciplinary chronic pain management, but also in social constructs associated with chronic pain management, and is now doing work to discover how chronic pain focused psychological treatments can expand their treatment effects to comorbid conditions. And she, based on the importance of her work, was invited to be part of this APA committee. So here's some of the outcomes of what the panel developed is that there were great or strong evidence for multi-component self-management in CBT for musculoskeletal pain, also for exercise and psychotherapy in general. What we also find, though, is that compared to some other treatments, the evidence is not crystal clear. There's enough evidence there to suggest things like MBSRs, mindfulness-based stress reduction would be good, that acupuncture would help, that exercise and yoga would be good, but exercise might be better, and that interdisciplinary treatments are better than exercise alone. And then this other category here suggests that when you're trying to choose between these different interventions, there's really not a lot of data available to help us make that choice. And that doesn't mean that there isn't one that's better. It's just that right now, I think the research and the data that are available, not only in the combined published research body, but also in the body of knowledge that we're sharing with one another, there's just not enough data available to help guide us. So if you get a chance, I recommend you look at these clinical practice guidelines as they become available, and use those as a guide for what treatment you might want to start with. This is a nationally relevant group of experts, and so this is a good place to start. There are some meta-analyses, and I won't go into depth because what I find with meta-analyses is meta-analysis doesn't necessarily mean that this is the be-all to end-all recommendation. This is one group's interpretation of the combined data that are available, where they looked at self-management, tailored behavioral interventions, CBT, self-management act, and psychoeducation. And they looked at them across a number of different formats or venues, relying on different theories of treatment. And the outcomes that they found is that really, by and large, and this has actually been true in my experience of psychosocial interventions, is that if the goal is to move the needle on any one relevant outcome for chronic pain, it's going to move a self-reported disability. These psychosocial interventions seem to be very good at addressing psychosocial or pain-related disability, but also pain interference. They don't do as much for pain intensity. And quality of life, I think the more recent data are more robust for things like pain coping and quality of life. But pain intensity doesn't seem to move very much, as I mentioned earlier. So let's talk a little bit about some of the more commonly used treatments and just get an introduction to them, starting with first and second wave therapies. For that, I really mean CBT. For that, I really mean, some have a CBT with a capital C, but we're doing a better job now seeing more mixed. The best example of that is cognitive behavioral therapy, in my mind, cognitive behavioral therapy for chronic pain. There are some wonderful individuals who helped develop this. Individuals I've interacted with around it would be Jennifer Murphy, so Dr. Murphy, Dr. Greg Beeler, Dr. Jennifer Funderburk. They've done great work in the VA. In the Department of Defense, there's a group of us, including Dr. Cindy McGarry, myself, Dr. Jeff Cuddy, and Dr. Katie Kanzler, Dr. Ann Dobmeyer, who have all come together to develop a brief component of CBT for chronic pain. This is now a highly research manualized intervention. I included a QR code that will link you directly to the therapist manual for this. It's been studied thoroughly, especially in the VA, which is the largest health system in the country. And you can see a list of treatment components here that show how this is a modular treatment that includes things like exercise and pacing, stress management, engaging in pleasant activities, cognitive coping, and sleep management. The research on this is increasingly robust. So we're starting to see that this does seem to work fairly well for at least some people, but it's also important for us to recognize over time that pain assessment in general is not, or pain treatment in general is not a one size fits all. But I will say that if you're uncertain of what else to do, CBT for chronic pain fits very well into the CBT recommendations that were put together by the APA Clinical Practice Guideline Committee. So if you're not sure what to do, going in and grabbing this manual might be a great place to start. Generally speaking, there's encouragement to engage at least in goal setting in the beginning to help individuals understand what their goals might be, and then to really encourage that if you're going to ignore some modules, do not ignore the module on pacing. And then the other modules like stress management, pleasant activity, cognitive coping, sleep management, those you can collaboratively work with your patient to identify what works best for them. But we found this to be a really great treatment resource. If you're not sure or don't have anything more specific, it's a wonderful place to start, and it's going to help most of the people you see, I think. For third wave interventions, we come to mindfulness-based interventions and acceptance and commitment therapy. So mindfulness is something that I've dabbled in. I don't have nearly the depth of experience that I have with CBT, but I do have some experience with mindfulness. Of course, for the uninitiated, and I imagine in a group like this, everyone is initiated to mindfulness. We're all aware of it. It's starting to gain increasing attention, not only in scholastic, academic, and clinical circles, but also out in the general public. But it's this idea that a person can achieve, or to help a person achieve, a mindful state where they can be open, non-judgmental, curious, accepting, and compassionate, but specific to their experience with pain. There are a number of different ways this manifests in terms of its manualization or structure. One would be mindfulness-based stress reduction, another would be mindfulness-based cognitive therapy, and of course, those are only two of several. And mechanistic studies suggest that when you're using mindfulness for pain management, you're really engaging in an activity that improves emotional regulation and attention control as key mechanisms for helping a person improve their management of pain. For acceptance-based interventions, or for ACT, for chronic pain, ACT suggests that you develop some kind of cognitive flexibility through acceptance, awareness, and behavior change. And it comes along with different components that encourage this concept of developing oneself as an observer of pain. Instead of being in the experience of pain, observe yourself being in the experience of pain. Have some attention to the present. And all of this is to allow a patient to defuse themselves from their emotional and cognitive experiences related to their pain. And that gives them some mental distance from the pain experience that allows them to develop a plan and engage in a plan that will help them pursue value-driven goals. And so it's this idea that pain doesn't have to drive what a person does. And it may be, and I think it's reasonable to say that a lot of CBT interventions for pain are in response to the pain. We need to respond to the pain experience. We need to squash this. This is bad. Whereas ACT might look at it as pain is something that you're experiencing, but it doesn't have to be determinant for what you do in your life. And so let's teach you some strategies to help you defuse yourself from pain and actually engage in value-driven behavior so that you can do things that are meaningful to you. And when you do those things, the expectation is that pain will diminish, and that the way you think about it, and because pain is so multiply determined and so complex, if you're engaging in these value-driven activities, then pain should get better over time. And what we find is that the effectiveness of this treatment, or the efficacy of these treatments, tends to be pretty good, that they have at least moderate effects for anxiety and pain interference. And pain interference, as I mentioned earlier, is really on par with the importance of what I was talking about with pain disability earlier. How much is pain interfering with meaningful life activity? In my mind, pain interference and disability are two of the most important outcomes you could assess if you want to know whether or not a psychosocial, or really any intervention, works in a way that's going to make a person's life better. So right now, meta-analyses suggest that there are good moderate effects, small effects for pain intensity, depression, disability, and quality of life. I think actually disability is probably better than this meta-analysis suggests in terms of outcomes from ACT and mindfulness interventions. So these can also be a really good place to start. Here's just a summary, but for the sake of time, because I do want to get to some of these other interesting things, I won't get into it. But the meta-analyses that have come out seem to support both ACT and mindfulness as good options. I also want to talk a minute, just because of the depth of experience that both Cindy and I have in interdisciplinary pain management, is to talk about interdisciplinary pain management strategies. For disclosure, I come at interdisciplinary pain management from a functional restoration theory. That's a theory that's really driven by Bob Gatchell. It was really impressed upon me in my training with him. And functional restoration suggests that function is the primary outcome of good pain rehabilitation. So in interdisciplinary models, of course, you have an interdisciplinary team that represents different specialties that all come together. And in order to be interdisciplinary, it's important to recognize that multidisciplinary and interdisciplinary are different, and that Interdisciplinary means that all of these different specialists or specialties are working in harmony, which means they're focused on the same outcomes. They have the same theoretical understanding of what chronic pain is and how they're going to approach it, and they don't interfere with one another. Multidisciplinary means you have multiple specialties working on it, but they may not necessarily be sharing the same view. So, and interdisciplinary is unquestionably better, but harder to do. If you want more details on that, we were fortunate to work with Bob and Ben Lippy to publish a manuscript, Interdisciplinary Chronic Pain Management, Past, Present, and Future in the American Psychologist. You can just Google that title. I think at this point it's been cited about 1,300 times, and it just goes to show that I take that as meaning that there's still a lot of interest in interdisciplinary pain management, and I'm glad, because if we agree that chronic pain is complex, then I think the best version of treatment we can give individuals who are experiencing a complex problem is a complex treatment. But there are obstacles to that are well spelled out in this manuscript. So I leave it to you to go and read that if you have a minute. In terms of meta-analyses that determine whether or not it works, we find that the effects or the effect sizes for interdisciplinary pain management tend to be moderate to very large. That's encouraging, and it makes sense. The doses of these treatments tend to be very high, although I will say that Jennifer Murphy, and I have a manuscript, I have her citation down below, published a really nice study about different VA-based interdisciplinary pain programs. The VA did a wonderful job for a while of implementing these programs at different sites. But because of the circumstances at the different sites, including what specialties were available, when they were available, and what patients were able to attend based on the rurality of the catchment, they found that the different programs that they had in the VA had different structures. So some would have people come in every day for 3 weeks. Some would have people come in just a few times a week for 4 weeks. So they all had different doses and structures. But what Dr. Murphy and her colleagues found was that by and large, the structure of the program actually didn't really seem to matter. It was more the interdisciplinarity of it. And by and large, when you look at the constellation of specialties that should be involved in an interdisciplinary pain program, it should definitely include mental health. It should definitely include psychology. And really, in many cases, these programs are run by a psychologist or a clinical or counseling psychologist, in some cases by a counselor or a social worker, just because we tend to have a more universal or holistic view of how care should proceed. And then that's great. And I think the added social skills of being in our profession helps organize all the other professionals and get everyone on the same page. Additional insights is that we've learned a couple of things that interdisciplinary pain programs do work really well for complex patients. I'll talk about that as I show some of my trial outcomes in a minute. That individuals who successfully go through these programs, who complete them, completion for me means that they attended about 2/3 of the sessions that were available for the interdisciplinary program. That those who do that tend to use specialty care at lower rates. They go to the ER at lower rates, they get fewer injections, they get fewer surgeries, and they're more likely to go to work. And so you get really nice, tangible outcomes. And these are important only because these are outcomes that third-party payers tend to care about because they affect the bottom line. And so that reporting those back to third-party payers can help in terms of propagating programs like this. And these programs can have long-term effects. So they can be durable. And this has been demonstrated in our research and also the research that Dr. Murphy has done and is published in his publishing. And those are just a few of the groups who are doing this kind of work. So I want to talk just a little bit about my trials because, they're my babies and everyone's baby is beautiful. And I want to share a little bit about what I've learned from the work that I've done so far. And I'll try to do this briefly. Starting with interdisciplinary pain management. So in interdisciplinary pain management, up until recently, there was this idea that interdisciplinary pain management, especially from a functional restoration perspective, really could only be done with individuals who were healthy or strong enough, who had chronic pain, but are strong enough to do the intensive rehab required. And so on the left, you see a pre-post trial for a study we did back in 2008 with military service members. And we had about, I think it was like 60 or 70 of them who went through this program. And you see their pre to post Oswestry disability scale. So the ODI is the measure, as I mentioned, that I think is the most important ODI scores. And you see that there was an improvement from pre to post in the score of about, this is about 7 points improvement here. And so we know that this was helpful. It led to a clinically and statistically significant improvement. But then I was able to replicate this study under an NIH-funded trial in the VA. And I chose the VA just because it is a complex patient population. I remember I've been lucky enough to collaborate with Dr. Tim Houle, who's a biostatistician out of Harvard Medical School, over the past like 10 to 15 years. And Tim, this was the first trial where Tim looked at the demographic table and looked at table 2, which describes the complexity of the patient population. He said, wow, Don, these patients are really sick. And he's right. They had a lot of comorbidities. They were taking a lot of other medications. They had a lot of medical and mental health comorbidities. And really, their improvement was roughly the same as what we saw in the healthier folks. So we're able to demonstrate that even for complex patient populations, these interdisciplinary functional restoration models are applicable. They also encapsulate benefits from functional capacity measures. So we find that over time, functional capacity improves. We also find that that constructs like the patient-reported disability, patient-reported pain interference, it incorporates both perspectives of psychological improvement and physical improvement over time. So even when you account for measures like the PHQ-9, the GAD-7, the PCL, or the pain catastrophizing scale or chronic pain acceptance questionnaire, those will take on some variance of the outcomes of these programs, but so do all these functional activities and functional rehab. So incorporating a good occupational or physical therapist in the work you're doing can be very helpful. What we also know, though, is that these interdisciplinary pain programs, if they're not emphasizing changes in opioid use, do not in and of themselves result in decrease in opioid use. You have to add an opioid taper as a formal part of these programs to really address persistent or problematic opioid use in these patient populations. From some of the work we've done in headache has really been exclusive to secondary headache. In this case, secondary headache that we're talking about would be post-traumatic headache, more specifically headache attributable to traumatic brain injury. This is actually hard work to do because these headaches, one, they're secondary, so they don't have a primary pain process like migraine does. Migraine has its own unique pain generators. Tension type headaches have their own unique pain generators that we can use to infer what might be going on. And there have been some exciting evolutions in pain treatment, including this the prominence now of these calcitonin gene-related peptide antibodies, these Aimovig injections. We see a lot of advertisements for these now for migraine. But for secondary headache, you don't get that luxury. Secondary headaches don't really have defining clinical characteristics because we're uncertain in some cases what the link is, in this case, between traumatic brain injury and the development of headache. We just know that a headache developed, but we also have a problem with definition because the definition, according to the International Classification of Headaches, and you see a link down at the bottom if you want to look for yourself. The definition for post-traumatic headache is basically that you have a head injury and that causes either a new or worsening headache. And the only way they can link the TBI mechanistically to the change in headache is through temporal relation. So the ICHD criterion is that it has to occur within 7 days. We published a study, though, where we compared individuals who had a headache that started within 7 days of head injury and from 8 to 90 days of head injury. And we found that there was no difference at all between those individuals. So this 7-day criterion as a definitionally close temporal relation is actually just kind of an assumption. And if you look at the ICHD-3, there's an asterisk next to it that just says there's no evidence to support this. This is just an idea we had. 7 days seemed close. So I think the definition is or the research that are coming from our groups and others are starting to show that these time definitions are really not what we thought they were. They're not as specific or as meaningful as we thought they were. So for post-traumatic headache, one of the significant downsides for post-traumatic headache is there are no treatments that really work for it. There are no frontline pharmacotherapies. There are no frontline behavioral interventions. Behavioral interventions are widely recommended by the International Headache Society because, of course, they have a safer side effect profile than pharmacotherapies do. So our research group And this was under grants that were led generally by me, but also Cindy and our collaborator, Dr. Blessed Eben. He's a PM&R physician who's now out of Greater Los Angeles VA and UCLA Medical School. We developed a manualized intervention in collaboration with Tim Hool and Don Penzine to address these headaches. And you see what this intervention looks like. It's basically just a glorified relaxation protocol that has some cognitive therapy attached to it, a couple of behavioral components too, and it's relatively brief, 30 to 45 minutes across 8 sessions. And so we tested this against, in this case, we were looking at post-traumatic headache among military veterans has a strong PTSD comorbidity. And there was a theory at the time being around 2014 to 2020 when we did this trial, there was a theory at the time that PTSD might drive these headaches. And there was good reason to believe that because the post-traumatic headache varies with PTSD symptom severity. So we were lucky enough to also partner with Patty Resick to look at cognitive processing therapy as a comparison arm. So we had our CBT for headache or CBTH, compared that to cognitive processing therapy and compared both of those to usual care. Now, in this case, usual care was way high impact usual care. It was in a polytrauma rehab center in the VA. People were getting medication treatments, injections, Botox, physical therapy, complementary and integrative health treatments. So it was really, really high impact usual care. And what we found is that our little 8-session manual blew everyone else away. It was by far not only a better treatment, but had durable effects at least up to 6 months. And 6 months is just when we stopped assessing. This was an effect that was strong enough that we were able to publish our primary outcomes manuscript in JAMA Neurology. It's one of my proudest achievements. That's why if you see me in other venues, I'll talk about it there too. And I apologize in advance, but I'm just really proud of it. What we also noticed, though, that was cognitive processing therapy was helpful. Another surprise for us, though, was that this CBT manual for headache actually did just as good job addressing PTSD symptom severity as CPT, which is a gold standard treatment for PTSD. So we were really surprised to see that. And I think that's another reason why there was some excitement about bringing this to JAMA Neurology. Finally, from my research, and this is before I move on to just a couple of minutes of hot topics before we open up for questions, is managing chronic pain in primary care. As I mentioned earlier, one of my prized colleagues in the work that I've done is Dr. Jeff Goody, who is known in and of himself, I think probably worldwide. He has a book, and I've seen him actually do book signings for managing pain in primary care. And he's worked alongside a number of really notable people. And so primary care is important for chronic pain because it's the one venue where people are most likely to get their chronic pain addressed. So Jeff and I worked with a large group, including Katie Kanzler, Cindy McGarry, and others, to propose to a grant to the Pain Management Collaboratory, which is a wonderful group led by Bob Kearns and his colleagues, Cindy Brandt, Peter Peduzzi, and a number of others. It includes constituents, stakeholders from the National Institutes of Health, the VA, and the Department of Defense, to really address pain management. We wanted to look at pain management in primary care. Here's one of our manuscripts right here, published in Pain Medicine back in 2020, describing our trial so you can get a sense of what we did. What we basically did, though, is we took that CBT for chronic pain manual I talked about earlier. We abbreviated it. So we worked with the Defense Health Agency under really the leadership of Dr. Jennifer Bell and Dr. Ann Dobmeyer to abbreviate this. We did it with a panel of about 30 national experts, created brief cognitive behavioral therapy for chronic pain, and then implemented it with a behavioral health consultant embedded in primary care. So the question was, can we deliver effective pain management from a mental health perspective with a mental health provider embedded in primary care? And the answer is yes, that we could do it. We found that while patients in that clinic, we did it in one clinic with about 43 patients, while they were working with their behavioral health consultant, they got really good outcomes from it. They noticed good pain relief. When we did qualitative interviews afterwards, the patients had a lot of compliments about the treatment. They really liked being able to get a complex treatment like that in primary care. They felt understood. Generally speaking, having a BHC, having a behavioral health consultant in primary care is better for the entire primary care clinic and everything they do. Go no further than the voluminous body of research that Jeff Goody and his colleagues have produced to describe that, but it seems to be particularly good for chronic pain. One thing we did notice, though, was that when treatment ended, there was some recidivism back to baseline. So Jeff, Katie, Cindy, and I are now working to address that through booster contacts in a trial going on right now. But we're excited to see that can be done in primary care. Of course, this was rolled out in the Defense Health Agency to military primary care pain clinics across the country. So we're pulling those data now to get a sense of what that looks like when patients get that treatment. But that's wonderful news. It's a brief treatment. It's done in 30-minute increments. Most patients get about 4 appointments to get a full dose of this treatment. And they show really good effects that are dose dependent. So that was really wonderful to see. Now I'm just going to take 5 minutes to go through a couple of hot topics, and then I'll wrap up so we have time for questions. And these are just some things that I've dabbled in or am dabbling in right now with some of my colleagues. I'll talk about some of my trials and what we're learning, and I'll just give snapshots of these. If you want more details, you are more than welcome to contact me with any of these things I'm involved in. I'm a fanatic when it comes to this kind of work. I will happily talk your ear off about it. So if you want to know any more, please let me know. I also am the son of a kindergarten teacher, so I work and play well with others. And if you want to join along and collaborate in research in these areas or just swap clinical stories and advice, I would love that too. I'm going to start with prehabilitation. So prehabilitation, as I mentioned earlier in this presentation, is this idea that you can engage in a psychosocial intervention before someone develops a pain condition. So the idea is we get them ready for it. This is most relevant for things like post-surgical pain. Post-surgical pain is a significant problem for 2 reasons. One, because it's quite common, but another reason is because it chronifies at very high rates. So individuals who develop pain after a surgery, and this could be surgeries related to cancer, abdominal surgeries, after they have a surgery, spinal surgeries, after they have the spinal surgery or have the surgery, they are likely to have post-surgical pain. That produces, if it's poorly controlled, it produces a risk for opioid misuse, and there's a high likelihood it becomes chronic. So we know that there might be some psychological interventions, even brief interventions, that we can give that might minimize the problems that occur after. And you need to go no farther than the work that's been done by the brilliant Beth Darnall, who developed Empowered Relief. And if you ever get a chance to read up on the work that she's done, it's amazing. And it's really catching on everywhere for good reasons. One, because it works really well. But 2, because I think and I don't know if this was purposeful or not, because I'm not smart enough to read into her process for developing it, but she seemed to really have considered downstream implementation of this treatment. It's a single session, 2-hour group-based intervention. It can be done in person or virtually. To help a person get ready for surgery. It can also be done after, but I'm attuned right now to the pre-surgical application of it, and it can be very effective. And I was certainly impressed by this. And it so happened before I was really familiar with Beth's work that my group here, including Dr. Paul Navity, who's been a very valuable collaborator over time, of course, Dr. Cindy McGarry, Dr. Meredith Stensland, we were working on projects looking at getting the most out of epidural steroid injections. So we have manuscripts here. You can see in the micrographic paragraph in the lower left-hand corner, there are citations for those. But what we found is that when it comes to getting a simple interventional treatment for low back pain, like epidural steroid injections, psychological factors are really important for that. And doing some kind of prehabilitation might help. So we developed a manualized intervention for that that's being tested right now. So if you're interested, I'll let you know how it goes. For cannabis and cannabis derivative drugs, this is very interesting because our patients are using it. Of course, they're using it in different ways across the United States based on the legal environment for THC and cannabis. There was a recent threat here in Texas to get rid of all THC and not allow it even medically. But different states are starting to see, really generally the trend for most states is an increase in the availability of cannabis and cannabis derivative products. We know that cannabis for pain is a little bit mysterious because of how complex cannabis is as a molecule, and it has 60 unique compounds in it. or as a substance, sorry. It has 60 different unique compounds or molecules in it. But of course, THC and CBD have the highest concentration, get the most attention. There are risks associated with its use, and how it's used can have an impact on pain relief, and also its risks. So inhaled cannabis and also edibles tend to have the greatest risks associated with them. When you put it in a pill form or something that is absorbed a little more slowly, you tend to get good clinical benefit that's a little more durable with less risk. And I know all of this just because you see, I have actually with Dr. Cyril D'Souza, one of the first VA sponsored trials. It's a $10 million 5-site, multi-site trial to look at cannabis derivative products for pain. And one of the reasons why we're doing it is because the body of research up until now for cannabis derivatives for pain is very weak. I'll skip through this, just that there may be some indirect effects of pain or of cannabis on pain through things like PTSD, anxiety, and depression. So even if cannabis doesn't affect pain directly, if it can improve depression, anxiety, and PTSD, then it might help with pain. So our trial is a 4-arm trial. We're looking at THC, CBD, the combination, and placebo, of course. And we're using an 8-week treatment design across 5 different sites. So I'm really excited about that trial. We're halfway through our recruitment. I'll let you know how it goes as we proceed, but there's a lot of excitement there. And then finally, Cindy and I are starting to work with our collaborators on artificial intelligence for pain management. So AI produces a lot of opportunities for growth. It also produces a lot of risk. We're engaged in doing this work right now. We are actually developing, and this is a big component of this, is the work that's been done by Dr. Dana Turner and Dr. Tim Houle, who developed the HAP-RED diary. It's an AI headache diary out of Harvard Medical School and Mass General Hospital. We're adapting that for post-traumatic headache. So we use a multi-step process, and I don't have time to go through all of it right now, to create a predictive algorithm that uses, it's a Bayesian algorithm that will learn from itself over time. So this is the AI part. As a person fills out their headache diary or their pain diary over time, it looks for patterns in their pain experience. And we tell it what to look for in terms of risk factors and give those risk factors weights. We use some of our previous or existing data sets to help develop and specify that algorithm. And then as the patient fills it out, it learns about them over time and then changes the weights of the risk factors over time. And then we'll make daily predictions saying there's a 54% chance that you're going to have a bad headache today. It's quite likely. And then it will use the same algorithms to forecast treatments, especially self-management treatments that might help. So in these circumstances before, you did some deep breathing. That deep breathing seemed to help, so we recommend that you do it today. It's a really nice use of this machine learning AI stuff to help us use the repeated measures that are recommended for pain conditions and get the most out of them. Make some sense of them and do it in a dynamic way where these models learn from themselves. So I'll end with this, that chronic pain is, of course, complicated. Chronic pain is difficult to work with. Chronic pain can be scary for our patients and, frankly, for all of their providers. But it's one of the most common and most impactful most impactful problems our patients will experience. It is my belief that clinical psychologists, counselors, social workers are uniquely situated to help these patients in a way that no other provider can. And I hope, if you're not doing it already, that you engage in it. And if you are engaging in it, I hope that you share your successes and your trials with the rest of us so we can all learn together. And of course, I'll wrap up there. If there are any questions, please feel free to email me, and then I will stop sharing my slides so that we can get to questions and answers.
Okay. Well, Dr. McGarry, thank you so much for a packed webinar that had a lot of great information in it. As I'm sure you can imagine, there were several questions. I have categorized them into basically 2 categories. One will be clinical application, the other is assessment, and there are many more that I'm sure that we won't be able to get to, but we will forward those to you after. In terms of clinical application, one of the questions has to do with incidence of chronic pain since the pandemic. Can you speak to what you've seen?
That's a great question. That's a really great question. So I don't know about I haven't looked at the epidemiology of chronic pain after the pandemic, but For the Pain Management Collaboratory, this is a group of, it started as 11 different multi-site pragmatic trials for pain management that were all being done. And this is the group that's under Bob Kern's leadership that I get to be a part of, which has been really nice. We did start to ask about the influence of COVID on pain, and it has an undeniable influence. Now, whether or not that's influencing the prevalence, I'm not sure. Although I think if we were all to take a guess, we would say that, yeah, it definitely is probably going to contribute to an uptick, especially long COVID. But even having COVID and having had COVID changes the way people experience their pain. It also changes the way they respond to pain treatments. And so and generally can make them worse. So COVID was certainly a compromising condition for all of us when it came to chronic pain management. That's an excellent question.
Thank you for that. We spent a good deal of time talking about the multidimensional nature of pain, and several people had some questions about limitations of pain scales as it relates to that multidimensional nature. How can clinicians realistically balance comprehensive assessment with time constraints and the typical practice settings?
Yeah, that's a great question. So I think first is we recognize that time constraints are different for everyone. So time constraints for some people mean that I have 1 minute, to get this because I'm seeing lots of patients and I have a lot to do. Some it may mean 5. I think it's important really just to take the information that we talked about today and this multidisciplinary model and just really think for the patient that I'm seeing, if I know them already or if I'm about to learn about them, and do a good interview, but then use that information to think, what are the most important things that I need to be assessing here? And for me, I think what that really did for me is I started to jettison the numeric rating scale. So I stopped doing pain ratings because I thought, is that really the most important thing? I don't think so. If we define importance as what's going to guide treatment and help me know whether or not treatment is working, sometimes I'm just not sold on that. So I just have to make good choices about the measure I choose. And sometimes that also means that I have a person coming in who has their medical record is clear that they have had problems with depression. They have had major depression for a long time and they have chronic pain. I know that those two interact, so I better have a depression measure in there. And I think unfortunately, that's the best guidance I could give you. I wish I could give you a better answer. That's the state of things right now. I will end this comment with a plea. If anyone does have like the golden answer, let me know and we'll figure out a way to commercialize it and make $1 billion. But for right now, I think the best we can do is just to say to think about which components of that multidimensional model might be the most important in your clinical judgment and assess those. And if they don't seem to work, then the great news is you can pick some other ones and use those to guide.
Sticking with assessment for just a bit longer, one question relates to how you can detect malingering, especially when there might be secondary gain, particularly to be able to access opioid treatment and disability benefits.
No, that's another really great question, and it's a tough one. Only because malingering has been addressed pretty thoroughly in the research literature. And there was a time where I think estimates of malingering in chronic pain populations were relatively high. But that's been adjusted. Our thinking has changed over time. Is that we now recognize that malingering isn't as clear, or the way we were measuring it isn't as clear as we originally thought it was. Sometimes what you get is not so much malingering as symptom exaggeration. And the important difference is that malingering suggests that there is a secondary gain issue involved. For symptom exaggeration, the gain is primary in that the individual is worried. Chronic pain patients experience this a lot. They worry that because pain is a purely subjective phenomenon, that you might not really truly believe what they're experiencing. And so because of that, they might exaggerate their symptoms as a way of really helping you understand that this is a big problem. So it's not so much that they're malingering. True malingering actually occurs less than you think it probably does, but it does occur. But symptom exaggeration is probably more likely to occur more often. And one example of that I really remember is I had one patient, she ambulated into my clinic with a noticeable limp. She had chronic knee pain, and so a rheumatoid arthritis that was affecting her knee, or osteoarthritis in her knee. And she ambulated in with a noticeable limp, and she ambulated out with a noticeable limp and left some of her personal belongings in my office behind. So I ran out of my office to be a good person and deliver them to her. And when I went around the turn in the hallway, her gait was perfectly normal. And when I talked to her about the difference, she told me, yes, the goal, I just need you to understand how how does that this is a problem for me. So in terms of ways of cutting through that, there are some measures that will help you do that. There are some functional tests that can help you do that. I'm not an expert on those. I have used them from time to time, so you can look into the literature on that. I would definitely encourage you to look at more contemporary literature, last 5 years for sure, just because anything before that was a little more misguided. But you can help tease those out. But if I were to give you advice on what to assume right away, assume the symptoms are being exaggerated, not that the person has secondary gain.
That's a great distinction. Thank you. Other questions relate to what you see for the future. So, how might electronic diaries or digital health apps and tools change the way we track pain and work with those who are involved in pain management treatment?
Yeah, that's my jam. So let's talk a little bit about that. So I just talked about the AI stuff that we're doing right now. And I think part of it is going to be the careful inclusion of these opportunities to use a lot of prospective and honestly retrospective data to condition how we assess and frankly treat pain over time. So if we can learn about an individual's experience, we can then have a tailored model of pain assessment and treatment that will adjust itself based on how their pain changes. And even within a day, a person's pain is going to vary, sometimes in systematic ways. So being able to have a dynamic model like that that will take advantage of technological advances will really, I think, do a lot. I'm excited to see what happens, not only because I'm a stakeholder in it with the research that we have right now, but because I'm one of those dorks who thinks that AI is really cool and I want to see what happens. I also will say, though, that as a caveat, we should always approach technology like AI with some cynicism. There is a black box phenomenon with these AI models where they're engaging in operations that we can't see. We don't exactly know where the data are coming from. We don't know what the data are upon which these have been conditioned. And if you've ever tried to interrogate an AI model like ChatGPT to ask it, how do you know this? It's not crystal clear. It doesn't always come right out, and sometimes it will hallucinate and straight up lie to you. So we want to be careful about that. But I do think one of the emerging ways that we see is that we're going to start to incorporate these kinds of technologies into the way we measure pain and the way we treat pain over time. I think we're also going to start to see these things integrated into the electronic health record more. That's something I see over and over and over again. If this is the one-stop shop for how we manage our patients, then I want flags in there that tell me when I should look for things. I want advice on what assessments I should be doing to address the question earlier. Hey, AI, use the medical record to tell me what measures I should use today. So those things will improve over time as long as we're careful about it. But I think integrating it into the natural flow of our clinical practice will also be helpful. And then in terms of these generative language models that can actually talk to you, I've seen some really great models people are developing to talk to people in a humanistic way about their pain that seems to in and of itself be healing. So I think just having an AI model that can be an ear to listen and give positive feedback. And as you can imagine, that has to be conditioned carefully, and policed. But yeah, I think that's another part of the wave of the future. So I'm sorry if I didn't address that fully, but that's just from my small corner of the world. That's what I see.
I think that was great. So we have about 60 seconds to squeeze in one
Oh
more, and
no.
we'll switch to a treatment related question. And that is, can you tell us about how we might intervene with patients who are not responding to typical CBT treatments? So are there any additional addendum interventions that have been investigated for non-responding patients? And are
Boy,
there
that's a
common predictors? One last piece, are
oh
there
yeah.
common predictors for those who won't respond?
Yeah, that's a great question. And of course, part of a much longer conversation. So there definitely has been work that's been done in that area in terms of being able to predict. And we have to talk about non-response from the standpoint of a person who receives a dose of treatment and doesn't respond versus those who drop out, right? Because they may have different constellations of predictive factors. We do know that individuals who have some comorbidities, a good example of that would be traumatic brain injury, are more likely to drop out. They're also the ones who are most likely to develop dose-dependent benefits. So in some ways, if CBT isn't working, more CBT can be the answer. I will also say, though, that just from my clinical experience, having a repertoire of pain treatments across a number of different theoretical models can really help. I used to really push back against ACT because I'm an oppositional person sometimes, and I didn't want to learn anything new because evidently I'm starting to get old and curmudgeonly. But I eventually adopted it because it's really nice to have as an alternative approach. And I've had some patients who didn't respond to CBT and responded very well to ACT. So right now, that's the best I could do. But if you want to reach out to me directly, we can have a more in-depth conversation because there is some more evidence-based guidance I can give you, just not in the 10 seconds that remain.